Thank you, Madam Chair. It's an honor and a privilege to introduce a constituent. Ed Hannon is the president and CEO of McDowell Hospital in Marion, North Carolina. He is here today on behalf of the American Hospital Association. In his role in overseeing a rural hospital, home health agency, rural health clinic, and physician services, he has over 20 years' experience in hospital and healthcare systems and outpatient services. Mr. Hannon, thank you so much for your participation in the hearing today.
Congressman, thank you. Madam Chairwoman, thank you, and I appreciate the opportunity to address you all today. I am Edward Hannon. I am the CEO of the McDowell Hospital in Marion, North Carolina, and chairman of the American Hospital Association's Governing Council on the Small or Rural Hospitals. It's a pleasure to be here today to speak to you on behalf of the nearly 5,000 members of the American Hospital Association. McDowell Hospital is a 65-bed, rural, not-for-profit hospital located in the foothills of the Blue Ridge Mountains of western North Carolina. While the recession has touched us profoundly in our area of the country, we are steadfast in our commitment to reform health care, which should start with expanding coverage for all. And we commend President Obama for making health care reform a top priority. Hospitals have been early and ardent supporters of efforts to make health care more affordable. We have worked to increase the focus on wellness and prevention, better coordinating care, utilizing comparative effectiveness research, moving towards the adoption of information technology, creating alternative liability systems, and reducing administrative costs. The President's proposed budget offers some welcome steps. However, we urge Congress to carefully consider the impact it will have on all hospitals, including the small and rural facilities. There are three main characteristics that differentiate the small and rural hospitals: our size, our small size and volume, our geographic isolation, and the type of population that we serve. First, lower patient volumes in rural hospitals mean that our financial position is more volatile, which complicates our abilities to position ourselves, develop accurate long-range financial plans and contingency plans. As a result, we're less able to weather the financial fluctuations, especially in today's economy. Next is geographic isolation. Rural communities across the country are self-contained and far from population centers and other healthcare facilities. In my case, the closest hospitals are more than 30 miles away to the west of us, across the mountains, and 25 miles to the east of us. Moreover, public transportation is practically non-existent. For many rural residents, preventive, post-acute, and other services may be delayed or foregone, ultimately increasing the overall cost of care. Finally, America's rural areas tend to have higher proportions of Medicare patients. For example, Medicare accounted for 58% of the discharges from my hospital in 2008. Any payment change or cuts to this program would therefore hit us especially hard. Our lower revenues and tight margins means we're less able to subsidize any losses. Now that you have a better picture of the challenges of small and rural hospitals, I'd like to outline how the President's proposed budget would affect America's small and rurals. The President's budget outline proposes reducing payments to hospitals where high numbers of patients are readmitted within 30 days. However, any policy that assumes that most hospital readmissions are preventable raises concerns. Determining preventable readmissions is complex. It's a very complex undertaking because the causes behind each readmission are unique. Such a policy requires thorough analysis of both the patient's hospital experience and the care prescribed for that patient after they're discharged. Further, some readmissions are planned in appropriate patient care, such as repeated chemotherapy patients. Any provision that does not recognize these legitimate reasons for readmissions may become an obstacle to patient care and for patient safety. The budget outline also proposes to bundle payments for hospitals and post-hospital acute care. While we welcome a careful and thoughtful approach to bundling, we first need to evaluate existing demonstration projects and gradually phase in implementation with appropriate tools and infrastructure for coordinating care and managing these risks. Some hospitals and healthcare systems already are organized in such ways that this would facilitate the bundling of payments, but many are not. Many of the bundling pilot projects focus on care that is not even commonly provided in rural hospitals, such as coronary artery bypass graft surgery. A thorough understanding of the unique obstacles of rural health must be taken before any of these new programs are put into place. It is critical that we want to shape a fair payment bundling system. The President's budget also proposes linking a portion of the inpatient hospital payments to performance on specific quality measures. Providing incentives for quality is a laudable goal that we certainly support. The fact is, hospitals, more than any other provider type, have a history of linking quality measurements and improvements to payments. However, we are concerned about this proposal because it cuts payments up front. We believe that overall savings can be reached by improving care that leads to fewer medical visits. The current pay-for-performance proposals used as a standard set of measures, which may involve procedures not performed commonly at small and rural hospitals. A way to address low-volume situations must be included in any pay-for-performance proposal. Before I conclude, I do want to offer the AHA's full support for several provisions of the President's budget outline. The President's proposals to permanently fix the Medicare physician fee schedule, to invest $330 million to address the shortage of health care providers in medically underserved areas, many of which are our small and rural hospitals, would enhance our ability to recruit and retain physicians. In addition, we strongly support the President's inclusion of a ban on physician self-referrals to hospitals in which they have ownership interest, and look forward to working with the administration and Congress to achieve this goal. Let me end by saying that hospitals are more alike than we are different. Together we form America's healthcare safety net. No matter the size of our staff, the size of our budgets or location, our mission is always the same: to treat everyone the best of our ability each and every day. Thank you for your time today, and I appreciate the opportunity to be here.